Thank you very much, Nora, for that warm introduction. Ladies and gentlemen, good afternoon. It's been a tremendous delight to have been part of your conference for the last 2 days. And I'm delighted that I could participate and contribute to many of the conversations over these last few hours. The world we live in today has changed drastically in the recent past, and I would argue not for the better. We are witnessing daily greater suffering, more polarization, a greater suspicion for international collaboration, and an ever-receding global solidarity. It feels truly dystopian. A good friend of mine recently introduced me to the poet Wisława Szymborska, a Polish poet, essayist, and translator, who was also a recipient of the 1986 Nobel Prize in Literature. And to her poem titled, "Nothing is a Gift," which in my view beautifully captures the current moment of wretchedness in our existence. And so it goes. Nothing's a gift. It's all on loan. I'm drowning in debt up to my ears. I'll have to pay for myself, with myself, give up my life for my life. Here's how it's arranged. The heart can be repossessed, the liver too, and each single finger and toe. Too late to tear up the Thames. My debt will be repaid, and I'll be fleeced, or more precisely flayed. I move about the planet in a crush of other debtors. Some are saddened with the burden of paying off their wings. Others must, willy-nilly, account for every leaf. Every tissue in us lies on the debit side. Not a tentacle or tendril is for keeps. The inventory, infinitely detailed, implies will be left not just empty-handed, but handless too. I can't remember where, when, and why I let somebody open this account in my name. We call the protest against this the soul, and it's only item not included on the list. Yesterday, I spoke at the German parliament about financing models for global health. I described how our world is increasingly faced with adverse global macroeconomic conditions and weakening growth prospects, persistent and rising inequity, escalating debt burdens, and limited fiscal space, increasing climate and disaster-related risks, rapid technological change, disease outbreaks, pandemics, an evolving burden of disease, and rising geopolitical tensions. The global majority are indeed moving around the planet in a crush of other debtors, some saddened by the burden of paying off their wings. Others must, willy-nilly, account for every leaf. Many find resonance in the amnesia of where, when, and why they let somebody open this account in their names. We all find ourselves in a world order we did not create, whose rules we hardly understand and comprehend even more little about how we arrived at the current circumstance. Our collective trauma and disability from ever-increasing polarization, nationalism, and supremacy means that we'll be left not just empty-handed, but handless too. A powerful metaphor and legacy of the consequences of declining equity. The existing international financial architecture, financing policies, and actions have fallen short. Yet, the unfulfilled aspirations of people around the world have generated momentum for reform and created the opportunity for transformative change. In the last lines of a poem, Ntobeko reminds us that we are not for sale and we need to resist. This resistance must come from all of us, not only from those of us in the global south, a collective I prefer to refer to as the global majority, as it is home to 80% of the world's population. But we must all resist and protest this current reality and allow expression of our values, our ethics, and our morals. Above all, these must trump pragmatism. Within our souls, we know what is right. In Ntobeko's words, we call the protest against this iniquity the soul, and it's the only item not included on the list of debts. Our souls cannot be bought or traded. There are some things money cannot buy. Even before the sharp declines in equity brought about by the COVID-19 outbreak and recent geopolitical developments, progress has waned and solidarity diminished. Writing in the 2018 Lancet Commission on Advancing Global Health in HIV Care, in the era of Sustainable Development Goals, my colleagues and I wrote, "The Sustainable Development Goals sharply elevate global health and development aspirations, contemplating a world that is far more prosperous, far more secure, far more healthier, and far more equitable, where human rights and dignity are universally respected, and where human development unfolds in a manner that preserves the natural environment." Yet, the 3 years that have passed since these SDGs were agreed have dimmed prospects for achieving many of these visionary aims. By contrast with the international solidarity, shared commitment, and increased investments that characterize the era of the Millennium Development Goals, much of the world has, since 2015, turned inward and towards authoritarianism, repression, a diminished role for civil society, a policy of austerity for public investments, and suspicion for international cooperation. As a result of civil conflicts that have yet to elicit an appropriate response, more people than ever have been forced from their homes and countries. And at a time when the fruits of scientific advances are so evident, denial in many quarters of the role of humankind in the degradation of our environment threatens the very health and well-being of our planet and its civilizations. Sadly, these words are even truer today than they were 8 years ago. I wish to argue that the skewed structure and asymmetrical financial, epistemic, and power dynamics of global health in its current form are both unsustainable and untenable. Instead of its promise of equity and social justice, global health as we know it has been characterized by a demise of the global. Features of patriarchy, racism, white supremacy, and saviorism, neocolonialism, foreign gaze, power asymmetries between high-income countries and low and middle-income countries, and the increasing lack of diversity, equity, and inclusion among global health practitioners and funders lie at the heart of what has gone terribly wrong with global health. Consequently, global health, as we witness it today, is inherently inequitable and is failing dismally on all measures of equity. The rise of nationalism, right-wing politics, and the erosion of democracy world over worsen these existing global health disparities. Many have argued that these power asymmetries need to shift gears from inequity to active allyship and power sharing. Yet, global health continues to be a field where high-income country actors see themselves as leaders. Although the decolonizing global health movement has exposed the deep inequities inherent within the current architecture of global health, this movement, prone to elite capture, faces several institutional barriers that prevent meaningful shifts in power. The lack of allyship in global health has recently manifested itself as vaccine apartheid, led by high-income countries who hoarded vaccines recently for COVID-19, Mpox, and Ebola. Importantly, global North funders, donors, and philanthropic organizations have enormous influence on all aspects of global health. They often decide who leads organizations, who receives funding, what diseases and interventions are prioritized, and most global North universities and international non-governmental organizations are unwilling to discuss the disproportionate influence of wealthy donors and funders because they fear jeopardizing their own funding. Reimagining global health, therefore, requires that we address the intersecting systems of privilege and supremacy that continue to limit our ability to achieve equity and justice in health. Inequities are not only about the needs and concerns of the disadvantaged, but also the systems that create and perpetuate these disadvantages. To borrow from the words of Seya Abimbola and Maduka Pai, I begin, quote, "Privilege is complex and relational. The social structures that create disadvantages are the same ones that create advantages from which many of us benefit," end quote. We need to recognize that the current structures benefit high-income countries, even when that work or science is completed in the global majority, and on whose back the careers, status, and prestige of many global health actors, scientists among them, rides. So how do we as scientists respond to a world with declining global solidarity? The task before us is enormous. It requires simultaneously leveraging governmental policies, financial backing, strategies, and well-defined priorities to tend to the development of science, technology, and innovation. Further, universities and scientific centers must fund research and development, create inclusive avenues to ensure that the talent pool incorporates women and other marginalized groups, and establish robust education policies that can stand the test of time. And it must be prioritized in countries where resources are scarce and in which the fundamental needs, such as food, war, water, famine, political corruption, and education, compete with research and development for funding. In all of this, and as we contend with the age of disinformation, the voice of scientists, clinicians, and activists like you is critical to identify and agree our priorities and investigate solutions in the face of these urgent challenges. This endeavor is even more important and acute for the global majority. To decolonize global health, we must constantly and consciously strive to remove all forms of supremacy within all spaces of global health practice, within countries and between countries. And at the global level, supremacy is not restricted to white supremacy as we use it in everyday language, or male domination. It concerns what happens not only between people from high-income and low and middle-income countries, but also what happens between groups and individuals within high-income countries and within low and middle-income countries. Supremacy is there, glaringly, in how global health organizations operate, who runs them, where they are located, who holds the purse strings, and who sets the agenda, and importantly, whose views, histories, and knowledge are taken seriously. Supremacy is seen in persisting disregard for local and indigenous knowledge, pretense of knowledge, refusal to learn from places and people too often deemed inferior, and failure to see that there are many ways of being and doing. Supremacy is there in persisting colonial and imperialist attitudes, in stark and disguised racism, white supremacy, white saviorism, and displays of class, caste, religious and ethnic superiority in the acquiescing tolerance for extractive capitalism, patriarchy, and much more. So in closing, what do I think the face of a reimagined global health landscape should look like? The pursuit of equity, social justice, and health justice must be at the center of all global health efforts. Those of us who have a loud voice in global health should collectively affirm our ownership of the field. And the global majority need to be supported to claim the space in global health that belongs to them and is proportional to the size of their population, the size of their knowledge, and the size of their problems. We need to convert the opportunities we receive into opportunities we can give, weaving networks of solidarity with peers and building collaborations across the global majority without necessarily dismantling South-North partnerships. In many global South settings, universities and research institutions are much more likely to have global North partners than in-country or in-continent collaborators, which are essential for building solidarity and learning across countries and regions and building communities of practice. Within all communities, there is a need to engage and to foreground the voices of women, frontline workers, and people with lived experience, since they are often invisible in national consultations and committees. Much too often, international donors and funding organizations who come as saviors prefer to fund projects that address their own interests on their own terms and with onerous reporting. This in turn leads to a waste of resources, lack of local buy-in, and loss of local research interest, and a lack of trust between grantees and donors. Even when research or implementation work is focused entirely on the global majority, much of the donor funds are given to agencies and institutions in high-income countries. And these high-income countries subsequently hold the purse strings and, by extension, the power in these relationships. This needs to change. High-income countries must be willing to yield some power if we are to grow a more equitable global health networks that can foster a more equitable world. I want to touch briefly on the role of the academy. Much of global health is conducted through universities and similar research entities. It's a major problem that academics are incentivized to focus primarily on personal development, like tenure, awards, publications, impact factors, and grants, often at the expense of real impact. Universities and academic institutes involved in global health need to be held accountable for creating structures and processes that incentivize academics to be better allies, giving credit to high-income countries and other more privileged low and middle-income countries for supportive allyship work and power sharing, and to be responsive decision makers on the ground who engage with organic local processes and indigenous knowledge, and engage with local partners as leaders of the process of knowledge production and its use. Importantly, governments in the global majority must invest more in their own healthcare delivery, research, and training to reduce their dependence on donors from the North. Situations, as we have witnessed, where countries like the US can weaponize programmatic global health funding due to their substantial influence, resulting in instantaneous loss of livelihoods and care for millions, should never exist. Building quality research and teaching institutions in the global majority is critical to reduce reliance on high-income countries to improve the overall quality, depth, and relevance of scientific training and research. The current global health landscape is heavily centralized and, in my view, too homogeneous. Global health remains too centered on individuals and agencies in high-income countries. And in my experience, and GLOHRA being a notable exception, most renowned global health entities have leaders who are white, able-bodied men with a degree from elite Western universities who lead organizations headquartered in the global North with ground operations governed from a distance. This needs to change. Finally, while decolonizing global health is a noble aspiration, it requires that systems so long entrenched and configured. Therefore, we need you as scientists and concerned citizens to continually question the skewed ways in which global health is being studied, is being taught, is being funded, is being researched, is being driven, designed, and implemented. The accountability and reshaping of power dynamics is at the heart of all proposals for this change. This is not easy, even for people and organizations that are avowedly well-intentioned and equity-focused like GLOHRA. But good intentions are not enough. It is my sincere hope that GLOHRA will be a powerful voice for and a key enabler of the type of global health movement we would all like to be a part of. It's also my sincere hope that, unlike Szymborska, future poets will present us with a much more optimistic view of the world and a much more optimistic view of global health, instead of the commentary that nothing's a gift, it's all on loan, I'm drowning in debts up to my ears. I'll have to pay for myself, with myself, to give up my life for my life. I thank you for your attention and the opportunity to share some of my thoughts on how we can reduce the receding global solidarity in global health. Thank you.
Thank you so much.
Thank you.